Welcome back to the second day of the Karachi Urology Week, 10th edition. We had an exciting day yesterday, and we had a very good audience in the conceptual base course yesterday. This morning we had an institutional rotation, and this evening session in bladder cancer. We have eminent speakers from UK, Dr. Mazhar Sheikh, who's a consultant urologist in Oldham, and Dr. Chris Bach, who is Director of Robotic Services in Aachen, in Germany. And then we have panel discussion on non-muscle invasive and muscle invasive bladder cancer. So without any further ado, I would request Dr. Mazhar Sheikh to take the floor and talk about non-muscle invasive bladder cancer. Dr. Mazhar.
Thank you very much, Professor Saab. It's an honor, and thank you very much for the opportunity to contribute my role. So today's the topic that has been assigned to me is related to non-muscle invasive bladder cancer, and what we'll be discussing and highlighting the monitoring the intravesical treatment options after failure of first line in non-muscle invasive bladder cancer. So we are all aware of the TNM classification, and today's talk will be focused more on the non-muscle invasive, which is up to T1 disease. In UK, we follow the NICE guideline for the fast track referral through GP. The snapshot is basically anyone over the age of 45 with visible hematuria. They need to be stratified and referred through urgent pathway. The most important part at this stage, I want to say, like you and me as clinician need to be sure our all approaches towards the care of our patient should be centered and holistic based on their needs and requirement in an evidence-based matter. Looking at the bladder cancer recurrence, they occur through four mechanisms: either incomplete resection, tumor cell reimplantation, growth of microscopic tumors, and new tumor formation. So primary tumor resection is the mainstay of adequate cancer control. So as we are all aware of the significant evidence regarding the importance of secondary look to reduce the outcome related complications, recurrence-free survival, and it also helped to provide the prognostic information and improve the outcome of intravesical treatments, including BCG. As we are all aware of that, there is about significant number of patients who have their primary resection in T1 group. There is a residual tumor about T1G3, could be up to over 30%. Now, residual disease accurate staging by relook can be up to 30% more significant rise, and there is a significant number of the patient could have muscle involvement, which was in the initial resection were muscle free. Now, we are aware of different risk stratification groups. I'm going to highlight the low risk, intermediate, high risk, very high risk as per EU risk stratification. And for the NICE, we have the risk stratification into three groups. That's low, intermediate, and high risk. There is an overlap, but if you look at the EU stratification, they have also subgroup into very high risk, which has high grade and carcinoma in situ. So this is a bit of overlapping, but you can see the differentiation between EU risk stratification and NICE risk stratification. Now, after doing the resection, they need to be stratified according to the risk group. And this is a table reflecting the different modalities and approaches regarding the follow-up. So I've highlighted the EUA, NICE, and American data, how they are followed in different regions. Looking at the EAU has recommended 3 and 12 months for the low risk, which is, as we know, PTA, low grade. And in NICE recommended because of the cost effectiveness and the facilities available, NICE has recommended 3 months and then 12 months, and we are recommended to discharge these patients after 1 year after optimal counseling. EU recommended after 3 and 12 months annual cystoscopy for low risk. In the intermediate risk group, we can see it's almost equal or similar side of presentations. between NICE and American. EU has just left it for the clinicians and local expertise to define the follow. Now, going to the high risk group and very high risk group, we can see EAU, NICE, and NCCN almost have similar recommendation for the follow. And we cannot just start them at 5 years. As you know, they are a very significant risk group and they have a high tendency to be progressed and have recurrences. Now, we are aware of these models of EUA scoring system, and I strongly suggest all of us should use them regularly. Now we have mobile phones and applications, so we can easily use them on regular practice. Now, at this time, I really want to emphasize on the need and importance of dealing with carcinoma in situ, which we all aware, if not treated optimally, can progress to muscle disease within 2 years' time. And it's not just a red patch, please. So please be very proactive regarding treatment. And I'm sure we are all aware of that. And especially in the few years back when we have BCG shortage, we were exploring the different options. So we have a good evidence that BCG is more effective than any intravesical chemotherapy regarding the carcinoma in situ control. But the result and the outcome can only be favorable if they are given minimum of 1 year or ideally up to 3 years. We are all aware of Sylvester data, which has been reproduced in recent past as well. So now we need to look at all the modalities that can be used for the histological diagnosis and also looking at the different optical technologies to improve the yield. Now, looking at the urine cytology, is there a role in this current environment? We need to be careful regarding using urine cytology. So I feel, and most of my colleagues will agree, that for the use in low-grade disease, there is no real need for doing a urine cytology, which has a cost effectiveness. It will not going to alter the management. It has a role in special circumstances. So we are aware of multiple different tests which have been in the horizon for some time. I have used NMP22, but again, I don't think so. None of the tests yet is available to replace as the primary tool to replace cystoscopy. So the gold standard cystoscopy to assess the tumor for the diagnostic and as for the surveillance pathway. Now, as I've been asked to discuss different modalities that we can use to improve the tumor visualization, there are multiple novel approaches, but are they in a position to be translated into day-to-day practice? There is a big question mark based on the availability of technology, resources, and other factors, especially in this current environment. We have seen COVID has given us the insight and reflection that none of the system is ready to deal with any problems. Cancer did not go away during pandemic, and we're going to see more patients coming, unfortunately, which have been waiting. So this is one very sophisticated modality called Raman spectroscopy. But again, I have not seen anyone using regularly. My colleagues will highlight me from the European side. It needs specific instrumentation, training. So I don't think so it's there to be used on day-to-day practice. Other option is an optical coherence tomography. Again, it uses high resolution cross-section images for the tissue. Again, it cannot be used on its own. So you need some other modality to be used. Now, as we are living in virtual world and a hybrid mode has been there. So again, there is another virtual cystoscopy. Again, the limitation. One is the radiation. Again, it cannot be dependent totally on this modality. Now, another fancy one is endoscopy microscope, where you can obtain fluorescent images of the cellular morphology of the epithelium. Although it's a non-invasive point imaging system, but we are not there to use it as a day-to-day practice model. Now, looking at all these studies, the most two promising one, which are mainly currently available in the practice, is PDD, which is photodynamic diagnostic, and the narrowband imaging. I have used narrowband imaging myself, but I don't have personal experience with photodynamics. So what is the objective of using this? We want to improve the cancer detection so we can have an optimal tumor cure and reduce the chances of recurrence and progression. There is a good evidence that these modalities can improve up to 30% increased detection. So how does PDD or fluorescein or blue light cystoscopy is done? We use uh, hypericin 5-aminolevinic acid, or its ester called hexyl aminolevinic acid. They are installed into the bladder about an hour ago and is transformed and converted into the active protoporphyrin, which is taken up by the malignant cells. And then we utilize the blue light, which has the wavelength of 370 to 440 nanomils, and that will transform the presentation of the malignant cells. So studies have shown over 30% increase yield in cancer detection. And for carcinoma in situ, it has shown over 60% increased yield. So looking at the images, we can reflect on the white light. You can see the image and comparing it to when the patient's bladder has been exposed to protoporphyrin, we can see this discoloration. The normal tissue is blue and the red discoloration is basically a tumor. So that can really differentiate between the effectiveness of PDD. Another modality which is easier to use and translated more effectively in normal practice is narrowband imaging, where the contrast between the normal urothelium and hypervascular cancer tissue is enhanced. So again, it has shown it will improve the cancer detection through biopsy resections. So the way it works, the narrow band of light is strongly absorbed by hemoglobin and penetrates only the surface of the tissue. Therefore, it increases the visibility of the capillaries and other delicate tissue surrounding structures. So here we can differentiate between the white light and narrow band imaging. You can see a red halo surrounded by the greenish tissue. So that area is significant positive. So that's how you can detect. And I have used in the normal cystoscopy, flexible cystoscope for the surveillance, and I strongly suggest it's a good model that can be applied in a cost-effective manner. So I'm just presenting this comparative table using different modalities. So if you look at the absorption mechanism, they all favor more in NBI modality. However, if you look at the evidence, there is stronger towards PDD. So the cost implication, accuracy, they're all in favorable. So these are the modalities that should be considered, and that will reduce the risk of residual disease when you are doing the TRPT. Now we are aware of this intermediate risk group, which is the one that we need to really catch it before it transforms and not responding to the treatment. So we have a good evidence reflecting the role of mitomycin 6 weeks, and if it's not working, then we need to consider BCG, and we need to have a very open and clear discussion with our patients regarding the role and the risk involved. So the two major modalities approaches regarding treating intravesical therapies, one chemotherapy and the other immunotherapy through BCG. So the mechanism of action of, as we know, that mitomycin is an alkylating agent antibiotic. It cross-links with the DNA strands and causes DNA inhibition of the protein synthesis. Same applies to gemcitabine, erythromycin, which are doxorubicin and valrubicin. They all interfere at the cellular level, predominantly the nucleic acid metabolism, and decrease the synthesis. So we have just highlighted the mitomycin role, which inhibits the DNA synthesis is highlighted. Now we have a very strong evidence in the favor of these intravesical therapy, especially mitomycin. We all aware of this data. We know EORTC scoring system and the other scoring have shown the significant importance of mitomycin use in the clinical practice. Now, another modality, which is if we don't have mitomycin, is apirubicin, which again inhibit the nucleic acid and it interferes the synthesis and function of DNA. Now, what are the different ways of approaching intravesical chemotherapy? First is as the standard of care, post-URBT, if there is no contraindication, immediate post-operative installation of mitomycin. We know there is about 40% risk reduction of tumor recurrence. The other modalities can be used. So what we know, the disease progression can be reduced and the recurrence can be halted by this approach. Now, if there is some evidence which is coming up that you can use other modalities along with BCG to improve and increase the chances of disease-free survival in these patients. So mitomycin has been used along with BCG in the high risk or intermediate risk as well after proper counseling. And if we feel these patients are not the best candidate for having radical cystectomy based on performance status and other factors. The use of salvage therapy, this is another mechanism which has been used in patients who, although are not responding to the primary first-line treatment, and again, we are exploring or preserving their bladder. We need to be aware of what are the models, what are the approaches through which these diseases are not responding. Either if the BCG is failing, what could happen? The disease can progress to muscle invasive. It can change into more recurrences than the failure. So we need to be careful and have a very open and proactive approach regarding dealing with these type of high risk groups. Now, gemcitabine, although has been used more in the systemic approach, it has been evaluated in the use in intravesical therapy. It has been responded well, but again, if I ask my oncologist, is it a standard of care? So we are not there yet. So it is her role, but in a limited patient group. So regarding the valrubicin, which is the only drug which has been FDA approved for the BCG refractory patient having carcinoma in situ, again, the PROMISE studies and the other trials, we have a promising data regarding the uses of docetaxel and other agents. But again, we need to be very careful regarding patient selection, their symptoms, and the holistic approach should be considered throughout the process. Just touching about the microwave induction hypothermia and electromotive drug administration, it also can increase the absorption of these agents into the urothelium and can improve the cancer control through the tissue penetration. So apart from BCG, there are studies in which we have used interferon along to have a dual combination approach, and we have seen some evidence that there is improved outcome in the cancer control. But again, it's not readily used regularly on the day-to-day practice. So we are aware of that BCG is the most important one, which has been around for some time regarding reducing the significant risk of recurrence and disease progression. So just touching the contraindication of BCG installation, within the 2 weeks, if the patient has visible hematuria, other symptoms that we are aware of. So there was one meta-analysis which has evaluated the data of over 2,500 patients, almost 3,000, comparing mitomycin C and BCG. In this trial with BCG maintenance, there was about 32% risk reduction for recurrence as compared to the MMC alone. But again, we need to be sure regarding the counseling process, what we are giving and what is the outcome. So as I have highlighted regarding the use of combination of apirubicin and interferon, which is an immune agent, the prophylaxis, the conclusion of this study, which was a very good evidence based in T1 disease bladder cancer, that BCG was more effective than the combination alone. So again, there is a lot going around, but what is the strong concrete evidence is again more in the favor of BCG. So people have used combination of mitomycin and BCG, but there is toxicity which can be significant, and that can really put the patients away to having this therapy. So the most important message, as we are all aware, that BCG minimum for 1 year should be given before doing anything, because the CATOS trial and all the evidence we have shown, minimum 1 year maintenance will going to improve the outcome regarding the bladder cancer control. So regarding the treatment of BCG failure and recurrences after BCG, don't forget about radical cystectomy and very proactive approach, and have an open discussion with the patient where we are, what are the options available. We can also have other options like immunochemotherapy, device assisted therapy, and a combination. So regarding the optimal doses, we have discussed minimum 1 year should be given, and the combination can be tried. In patients with chemotherapy failure, non-muscle invasive bladder cancer, if the patient with non-muscle invasive recurrence of bladder cancer after chemotherapy, they can benefit from BCG installation. The evidence has reflected that prior intravesical chemotherapy has no real impact on the effect of BCG. So if somebody has given mitomycin cycle, they are not responding, do consider BCG installation. So just this is my conclusion slide regarding intravesical chemotherapy has a critical role in the treatment paradigm on non-muscle invasive bladder cancer. Current evidence supports the use of intravesical chemotherapy within 24 hours of TURBT, which is standard care now, and shortly after nephroureterectomy for upper tract. As we know, the ODMID trial has given a good evidence about that. Intravesical chemotherapy for specific patient with intermediate risk disease consisting of mainly multifocal or recurrent low-grade disease is an appropriate first-line adjuvant treatment. BCG maintenance should be used. An appropriate schedule is currently unknown, but most of us are aware of the induction and maintenance regime for at least 1 year. But again, based on the availability of BCG, other factors, that can be altered after 1 year again. In higher risk disease, adding additional intravesical chemotherapy like mitomycin to BCG can improve outcome. What are the exchange and what are the stakes we have for the higher toxicity? So they should be considered in very high risk group with proper patient counseling. In the salvage setting, gemcitabine with mitomycin is there, but we have not reached the relevant data yet. So just bear in mind, although it's non-muscle invasive bladder cancer, we need to be aware of the role of radical cystectomy in patients, although who have high risk recurrent non-muscle invasive bladder cancer, widespread CIS, BCG refractory or non-responsive T1G3, or anything which we cannot control endoscopically and is not responding to the intravesical treatment, radical cystectomy has a role. Thank you very much for your attention.
Thank you very much, Mazhar. It's very comprehensively covered in a very short time. Non-muscle invasive bladder cancer, the intravesical treatments, current role, and what in case these intravesical treatment fails. And hopefully, when I take you through the cases, we will be able to see response. So this, the next session, I'll be presenting few cases, and I'm really honored to have Dr. Mazhar Sheikh from UK, Dr. Hafiz Qureshi from Indus Hospital. He's a consultant urologist with an interest in uro-oncology, and my dear friend Marco. Welcome, Marco. So Marco Reber is a consultant urologist in Dubai, UAE. He's has a special interest in non-muscle invasive bladder cancer, and it's a pleasure to have all three of you gentlemen. So let me share my slides. Okay, hope my screen is visible to all.
Yes, sir.
Thank you.
Yes.
Yes, sir.
Right. So I think my job is made easy, and I'm going to quickly brush up something that Dr. Sheikh has already described. We know that the important thing about non-muscle invasive cancer is its depth of penetration and its grade. So you have T1, which is invading lamina propria, TA, which is papillary without invasion. And when we say non-invasive, we essentially means TA cancer. And then we have a flat lesion called CIS, which is, although a non-muscle invasive bladder cancer, it's a highly aggressive variant of bladder cancer. Not all non-muscle invasive bladder cancers, which used to be called as superficial cancers, are the same. And the real difference comes from not only depth of penetration, but the grade of the disease. So the old classification of 1973, which grade them into 1, 2, 3, and unfortunately, the grade 2 was the misused grade, and we have very little clinical data on grade 2 cancers, and we always used to categorize patients as low grade and high grade, or G1 and G3, with very little data talking about grade 2. So no wonder that the classification changed, and we have WHO 2004 classification in which grade, either it's a low grade or a high grade, so the histopathologist really commit whether it's a low grade or a high grade cancer. Remember that the T1 can never be low grade. So T1 is high grade, and TA can be low grade as well as high grade. So what really different from the previous classification is the introduction of the papillary urothelial neoplasm of low malignant potential, which, although a malignant condition, but has a very low malignant potential as its name suggests. And that is in addition to the 73 classification. So grade 1 is either PUNLMP or it is low grade. Grade 2 is either low grade or high grade, and grade 3 is all high grade. So this is the difference, and now we have very specified clinical entities, which is low grade versus high grade. So my first question for the audience, and can we have the first poll, is just a little quiz to see how well you have grasped Mazhar Sheikh's presentation. So what is the preferred grading system for NMIBC according to the EAU guidelines? Can we have the first poll, please, Sharif? Sharif, can you share? Are you sharing the poll?
Yes, sir. Yes.
Okay. Zoom live, we expect things to be really very, very smooth. From the days when we used to have a slide in a carousel, which invariably gets stuck. But technology has also a few glitches. So people have started voting on the chat box, and majority are writing B. Few answers about saying D as well, but majority are writing B. Mazhar, any comments?
So, what do you suggest, Mr. Professor?
Well, you can vote now. Let's see the response, and then I think we should. You have time to vote. Okay, about 1/3 have voted so far. Come on, guys, vote quickly. You can only be wrong. That's the only thing. It cannot get any worse than that. Okay, I think people rest are shying from vote. So I'll stop sharing and share result with you. So vast majority think it's B. Hafiz, what do you think?
So it should be the it should be the 2004 classification, but I don't know that people have given the 2016 as well.
Okay, so 1973 was the original one,
Yeah.
and the WHO 19 and the ISUP 2004. So the correct answer is actually D. Anyhow, first MCQ of the day doesn't really matter. Let's go to the second one. Share the poll. Which answer is correct? If CIS grows into the lamina propria in a superficial manner, would it be considered as a flat lesion? It has to be called T1. It can be low-grade lesion, or it does not change the stage. So please vote now. Guys, vote. It is not identifiable. So even if it is wrong,
And as professor said, like there is no, the main thing is it needs to be interactive. So that's what professor is trying to encourage all of us. What worse would happen? There is no judgmenting or anything like that. Worst scenario, it will be wrong. So be it. We're just sharing the knowledge.
so I'm good. I'm happy that more than 2/3 people have voted so far, and I'm going to stop vote and poll, and I'm sharing the result. I'm really happy with the answer that majority are they're clear in their concept that it cannot be low-grade lesion. CIS is CIS, but if it grows, it should be called and labeled as T1. And if you read clearly, it says if CIS grows into the lamina propria in a superficial manner, which is T1A disease, irrespective of being a flat lesion, it is a T1. Okay, let's move on to the, stop sharing. It is not going away. Okay, next poll. What is correct for both TA and T1? Vote now. Okay, about 60% have voted. So maybe a couple of more votes and we can end the poll, 70%. Good.
So professor, the most important thing what I've noticed, it's good to see that D has been marked by only one.
Good. So I'm going to end the poll. 70% have voted. And the result is that majority think it's A. Marco, I need your input on this one.
Yes, I couldn't vote because there is some dysfunction here.
Okay.
Yes, I think the B is in my opinion is the right one. The prognosis depend on the grade basically.
Yeah.
But yes, also A could be a trick answer. Okay, both are no invasive tumors. Yes, because as considered as no muscle invasive bladder cancer as well. Then there are two possibilities, but the strongest one, in my opinion, is the B1.
Okay, great. Thank you very much, Marco. So I think the important thing to know is that the TA and T1 are two different diseases, so they cannot have the same genetic path. Second thing is that, as Dr. Reber also pointed out, that their malignant potential is different. The third important thing, that message is that when we say invasive, we only say invasive, we actually means T1 disease, invasive to lamina propria. But when we use the term muscle invasive, that's what we mean by PT2 cancer. So, right, let's take one more poll and then we go on to the case. Which statement is correct about urine cytology? And Mazhar has talked about urine cytology in his presentation. Kindly vote now. So half of you have voted so far, and I am happy that people participating and getting interactive. That's the whole idea of this, this presentation that I would like you to. So great. So I'm going to stop poll now and share result. And I think Hafiz, Azhar, Marco, our audience are getting smarter by every MCQ. So majority have correctly. Now, when I was initial into my practice, the laboratory used to write first morning sample is mandatory for cytology. I think this has come from the urinary AFB history. So when you have first morning specimen, cytolysis results in cell breakdown. And as a consequence, the first morning specimen is the only one that you don't need to take. You need to take every other sample, but the first morning one. So really good that our audience have overwhelming 75% have voted for the correct answer. So the diagnosis of bladder cancer rests on cystoscopy. Cystoscopy is the mainstay. When you're doing cystoscopy, a bimanual palpation, looking around the whole urothelium, which is visible, which includes the bladder, as well as the urethra, and if needed, the ureters as well. The prostatic urethral biopsy is often indicated in order to stage the disease properly, and particularly the CIS, which can be often missed on simple cystoscopy. So the bladder prostatic urethral biopsy are important. The core cup biopsies from the base of the tumor in order to get a muscle specimen without artifact is really very important. Complete resection of the tumor so that your intravesical treatment for NMI urothelial cancer can work. And then writing a proper surgical report and noting the site of the cancer is important. So these are the very important parameters which will help in long-term survival and disease-free status for your patient. Now, we know that what we do when we try to diagnose bladder cancer is we do and destroy all principles of oncology, which means that whenever you remove a tumor, you try not to spill the tumor in the surrounding area. And that's what we do as surgeons all the time. We remove it with the capsule, we remove it en masse. And based on this principle, first of all, the SICA was introduced because we are spilling a lot of cancer cells into the bladder and they get implanted into a denuded mucosa. But more importantly, the fact that we are, and SICA was in a way was a bypassing that problem. More recently, the en masse or en bloc resection of small, moderate-sized bladder tumors have been introduced. Although we do not have any long-term results so far that it is oncologically better than the piecemeal resection that we have been doing. But this is one way of doing, and in work that we have done and reported in the last World Congress of Endourology, we have shown two things. Number one, that the specimen quality is better and the pathologist is happy. And the second thing is that I don't need to take a separate muscle for the specimen. And 95% of our specimen had muscle in the primary tumor resected. So at least these are two advantages. It was a short 1-year follow-up, so we have not commented on the oncological outcome of these patients. So, and the other thing that I've noted in en bloc resection is the fact that the bleeding is very much controlled because you are taking care of the pedicle. And I think this has really come from our experience of use of laser, because this is the way you do laser resection. Second resection TUR is something which is extremely important, and it's important to do it for all, and according to the EAU guidelines, for all T1 cancers. And the advantage of doing a re-TUR is that you will be able to stage the disease properly. If you have missed out on a T2 cancer and this patient undergoes intravesical treatment, it would not be for the next 5-6 months that you would realize that you were treating this T2 cancer as a T1 cancer. And you have missed the important window period in which, if this patient is appropriately treated for a T2 cancer, he or she may have had a better outcome than giving intravesical treatment for T1 cancer. So upstaging of disease is something that is there. It reduces the recurrence rate. It is able to completely resect tumors so that the intravesical treatment works better, because on an intact tumor, your intravesical BCG and MMC would not work. So this is an important thing. I know patients don't like it. Financially, it is not a feasible thing, depending upon your financial models. But this is an extremely important step for high-grade T1 cancers to be re-biopsied and re-resected. I'm going to go on to the first case now, and this is a 63-year-old male, 30-pack year history of smoking, a large volume bladder cancer. And I did the first resection for about 1.5 hours, and I was able to resect about 70% of the tumor. And then I went in again, and I resected for another 45 minutes to an hour, and I could not complete resection. My question to the audience is to think about this case, and I'm going to present 2 more cases, and then we're going to discuss with our panel of experts of how to manage these patients. So again, 63-year-old, you can see a CT scan, significant amount of tumor on the lateral wall. You can see that it's a papillary tumor, doesn't look like a sessile tumor or a muscle invasive disease, but I've not been able to resect it completely after 2 resections. This is the second case, a 56-year-old male with 20-pack-year history, TURBT for an isolated 4-centimeter posterior wall tumor, as you can see on an ultrasound. The histopathology indicated a high-grade bladder cancer. The biopsies from the prostate, which had some hyperemic areas, indicated that there is a prostatic stromal invasion. As you can see, that this is the prostatic urethra. This is the prostatic urethra. This is the urothelium with high-grade disease. And this is another focus of high-grade disease in the stroma. So we have a patient with a stromal high-grade focus of urothelial cancer. Our third case is a 67-year-old lady. She has been chewing tobacco, and Marco, you may not know, but chewing tobacco in Pakistan is pretty common in India and Pakistan. Mm-hmm. So she has been chewing tobacco for over 40 years. She presented with gross painless hematuria, and she has complete resection of the anterior and lateral wall of about 6-centimeter tumor. Histopathology, as you can see, is a high-grade invading lamina propria, which is T1 high-grade cancer with micropapillary component. I've been told by pathologists that micropapillary is indicated here, as I'm pointing out. So repeat TUR at 4 weeks show no muscle invasion. So we have 3 patients, and I'm going to present the cases again for discussion. And before I move on to discussing these patients, I'm going to just highlight again that the third case had micropapillary component. So as Mazhar pointed out, BCG is the mainstay of aggressive prostate urothelial cancer treatment. Over 1.2 and now probably 1.5 million doses of BCG have been used for bladder cancer worldwide. We still don't know clearly the mechanism of action of how BCG works, but we probably think that the possible involvement is BCG works by internalization with secretion of cytokines and chemokines, which in turn activate the immune response. And as a result, the CD4 and CD8 are recruited in that area, the lymphocyte and the natural killer cell and granulocytes. And all this result in a local inflammatory response, which is responsible for how BCG takes care of non-muscle invasive bladder cancer, particularly CIS and high grade. So the principles have been very well defined for BCG. Although the mechanism it's not very clear, but it requires an intact immune system. So if you're immunocompromised in any ways, BCG is not going to work. BCG has to come in close contact with the bladder cancer cell. So it's important that your tumor is completely resected. The cellular inflammatory response to BCG is, as I've said, through CD4 and CD8 lymphocyte and natural killer cell granulocyte. The humoral immune response, which is also initiated by BCG, results in IL-2 and IL-8 and other interleukins and interferon, which works through tumor necrosis factor in order to achieve the excellent result that we have seen over the years. So currently, the BCG is indicated in high-risk non-muscle invasive bladder cancer, which is either TA high-grade, T1, TIS, multifocal recurrent greater than 3 centimeters, be it for first-time or recurrent bladder cancers. And as Mazhar said initially in his presentation, that those who are BCG naive or those who have previously had chemotherapy may respond to BCG because they work in totally different fashion. So so this is the efficacy of BCG. The 2 problems with non-muscle invasive bladder cancer, i.e. the recurrence rate and the progression rate, are both significantly affected, improved by BCG comparison to TUR alone. And this is level 1A evidence for both that progression to high-grade cancer or T2 disease and recurrence rate are both significantly affected by BCG treatment. So let's go back to the 3 cases I presented and let's take a poll on this one. So the first case was, again, to remind you, 63 male, significant bladder tumor, couldn't be completely resected after 2 TURBs. Can you share the first poll, please, Sharif? The next poll. Okay, you can vote now. So what is the next step in the management of that patient? Consider intravesical BCG, redo TURBT to complete resection, intravesical chemo, or radical cystectomy. And I would like Marco to please comment on the outcome, please, on this once we have the poll results.
So we'll wait for the results and then I will give you my comment.
Thank you. You have 5 seconds now to complete, to vote until I stop the poll. Please vote now. About 50% have voted. And I'm going to stop poll now and share result. So Marco, this is what people think.
Yeah. Yes, but okay, we have to consider in this case the tough resection because you faced basically problems with this endoscopic bulk treatment. And okay, yes, so you did it in 2 stages, but in my opinion, still we miss a second resection, basically the conceptual second resection to see if there is any residual disease, microscopic residual disease that make us take other directories in our treatments. Then yes, I'd like to do a redo, sure, a redo TURBT to complete the resection and to get the disease status after the main bulk resection. And then yes, I didn't catch the histology of this case in your slides.
T1 cancer, not muscle was included, but it was not involved, and it was resected 2 times, and even then we have residual tumor. So would you like to go for the third resection?
Yes, in my opinion, yes. But the histology, I didn't catch that. The histology it was high grade.
High grade T1.
High grade.
Yeah.
High grade T1, yes. So high risk disease. But sure, this patient could be offered, in my opinion, either radical cystectomy, early radical cystectomy after the second resection, if it is with the still residual disease, or consider a bladder sparing attempt like with the intravesical BCG. But in my opinion, we miss still the second the second resection, the last resection, to define the disease status, in my opinion.
Right. Thank you very much.
Dr. Hamma, may I comment on this patient?
Sorry?
May I comment on this patient?
Yeah, absolutely. Please go ahead. Please.
Dr. Hamma, like this patient is sometimes it is impossible to do even the 3rd time redo TURBT. So obviously the extensive papillary lesion in the incomplete TURBTs for multiple times, like 2 times, one can consider the patient for the radical cystectomy, because we have even certain guidelines. Dr. Mazhar told about his last slide, that if the patient who have the papillary lesions and which are not resectable with the multiple TURBTs, so one can consider by doing the radical cystectomy. Second thing, the radiological one can assess the extension of the disease from the bladder wall as well. So I think the patient should be considered for the radical cystectomy.
Yeah, I agree
Yes,
with both of you.
It's a suitable option, of course. We have also to hear about the patient preferences as well. We need to talk with the patient about the possibilities of this case, but sure, radical cystectomy is the first option. But Ahmad, a question: what do you think about the new neoadjuvant and bladder treatment? I mean, to treat this patient in order to reduce the bulk disease with the schedule of neoadjuvant mitomycin, for example. I have some experience on this, and I found that you can simplify a lot the TURBT. So most of the tumors that are not resectable at the beginning, at the first sight, they become resectable after treating the tumor with the mitomycin in a neoadjuvant setting.
Marco, I agree with you that in our practice, I mean, I have anecdotal thing like you describing. The current guidelines do not support that intact tumor should be treated with intravesical treatment. But in practice, yes, intravesical treatment does have an impact, and that reduces the bulk. I have one case which we recently did and very similar outcome. But current guidelines would say that radical cystectomy is the treatment if you do not completely resect the tumor in 2 goes. But I agree with you that that's what can happen essentially. But we
Can
do
I
not
make a
have.
comment?
Thank you.
Thank
you.
Yes, Mazhar, please go ahead.
Yeah, so as you have highlighted, we are discussing an aggressive type of tumor because all the parameters, size, and all the factors goes in the non-favorable outcome. We know T1G3 is already 30% chances of disease progression. And we TURBT, we need to have an open discussion with the patient. Disease needs to be restaged as well. So I think the role of imaging will be there. And as we have shown the image, this thickening on the lateral wall, although we can't see it's extravesical disease or not, and we have not commented on the nodes, but I think we need to treat this disease very aggressively. And as you have highlighted, current evidence is not in the favor of giving any intravesical treatment, but it can be offered. But normally the intravesical treatment do not work if the cancer has not been cleared intravenous. But again, so I think we are talking about a challenging situation and patient needs to be explained. Cystectomy will be considered. Thank you.
Thank you very much. I think these are very important points for our audience, and this is what the current evidence-based is. So coming back to case 2, 56 male, heavy smoker, 4 centimeter posterior wall tumor on the bladder, and prosthetic stromal involvement. Share the next poll, please. What would you do next? Would you give intravesical BCG? Would you give intravesical immunotherapy plus TUR? Sorry, it's not TUR, TURP, yes. Intravesical BCG and radiation to the prostate, or radical cystoprostatectomy? Mazhar, I would request you to please share comments on the outcome of the poll.
So have we finished the poll yet? We just wait. So
Not yet. Yeah. Just over 50-60% have voted.
So again, it's a difficult and challenging situation. This is a young patient, and we are again seeing the aggressive type of non-muscle invasive bladder cancer factors. Prostatic urethra involvement, I think, need to be restaged again. I think before embarking and going into, I would suggest having another relook, restage that, because again, it was high grade disease, the recommendation to have a look, and I would sample the prostatic area again to make sure, because that will going to change the paradigm of treatment. But we need to be again very aggressive regarding the treatment. BCG has definitely a role, but before offering any treatment, I will restage and have a look in the bladder and the prostatic urethra to assess the histological diagnosis, and definitely explore one of the options. BCG is a good one, but in a young patient, we need to be proactive regarding assessing the patient factors and disease factor become making any final call. Regarding the option of radiotherapy, I saw anything. I don't think so. There is any role of radiotherapy in T1 high G3, because we know sometime on clinical oncologists do mention about radiotherapy for this, but real evidence is it needs to no role of radiotherapy for the prostatic involvement.
Thank you very much, Mazhar. So I'm really very happy with what the audience have voted. Well, one need to remember that prostatic mucosal involvement is a
Different.
prostate extension of the urothelial disease. Prostatic stromal involvement is essentially a T4A cancer. Remember that. It's a T4A cancer, and T4A cancer, irrespective of what you have in the bladder, requires radical cystoprostatectomy as the treatment. If you had T4, if you had prostatic mucosal involvement without stromal involvement, then intravesical, an extensive TUR, creating a incompetent bladder neck, a prostatic fossa, which is in continuity with the bladder, and then intravesical BCG. That's one thing. And some of the audience have voted in favor. So this is a very educated audience, and I'm very happy about that. Let's move on to the third case, again, reminding our audience and panelists that 67-year-old lady, heavy tobacco use, large 6 centimeter bladder tumor, poorly differentiated, non-muscle invasive T1 with a micropapillary component. RTUR again showed no muscle disease. And Hafiz, would you like to, let me share the next poll. Let's see the opinion of the audience, and then maybe you can comment on this patient. So the question to the audience is that what is the next step in the management of this patient? Intravesical BCG and systemic chemo, neoadjuvant chemo plus radical cystectomy, upfront radical cystectomy.
Masa, while we are having the poll, what is the uptake among the patient regarding radical cystectomy in Pakistani population? Are the patients happy to have cystectomy, or they try to avoid, or they prefer the non-bladder sparing option?
Well, nobody in the world would like to have their bladders removed, particularly what goes with it, particularly for men, all the genital organs as well. So nobody would like to, but if it is really indicated and you convince them properly, I may have a biased opinion because I receive patients who have already been mentally convinced by other people to get a cystectomy, and they come to me. Hafiz can shed some light. So I'm ending poll now, and I would like Hafiz to comment on this one and also on what Mazhar is asking about Pakistan, and then we can take Marco's opinion about what happens in UAE if people need a cystectomy.
Yeah, Dr. Hamad, usually I get a population usually from the low socioeconomic status. And obviously patients, in my opinion, whatever I come across with the patient, with the counseling and with the disease pattern, usually the patient accept for the radical cystectomy. Obviously, I have a small number of patients who are not willing for the radical cystectomy. So there are the two type of the patients I have. The most of 70% patient with the counseling and with the disease pattern, they accept the cystectomy, while 20 to 30 patients, they don't want radical cystectomy. This is the pattern which I receive in my clinic practice. And second thing, obviously, the radical cystectomy is one of the major surgery and which have a lot of complications. And obviously, they have usually very poor their social life status post cystectomy. So this was the Dr. Mazhar. We had a discussion with Dr. Mazhar as well around 2 to 3 months back. Dr. Mazhar must know about this case. That was someone known to Dr. Mazhar. So coming towards the pool number 7, this 67-year lady have the very poorly differentiated carcinoma. So and having the micropapillary the component. Obviously, this is one of the aggressive tumor, and so these type of the patients usually, in my opinion, I will go with the 70% of the people who have the upfront radical cystectomy, and obviously by doing the intravesical BCG might have the minimal role because of the micropapillary and very poorly differentiated high-grade urothelial cancer. So Dr. Hamad will further comment about this because he knows much more about these patients. So Dr. Hamad.
Marco, any comments about acceptability of cystectomy difference you've seen from Italy to UAE?
Yes, but yes, of course, this is a case with bad histological features because micropapillary is something that gives a bad prognosis to this patient. So we can share, all of us, we can share the indication of radical cystectomy. Maybe we can convince the patient to do it. In Italy, like in UAE, people accept even less any so invasive treatment. So they are very more keen to accept something bladder sparing option that you can offer. Okay, here intravesical BCG is not reliable, not too much reliable because of this histological pictures, but maybe this neoadjuvant chemotherapy and a neoadjuvant therapy and radiotherapy maybe it could be something that has not been listed in the pool, and I wanted to submit to the panel about this possible treatment.
Yeah, thank you very much, Marco, for your comments. And I think this is a nice view of things from UK to Pakistan and UAE and Europe as well. So generally, this is the thing that people would like to avoid cystectomy as much as possible. So let's move on. So the prostatic, as I've said, the prostatic stromal invasion is T4A disease. The prostatic ducts is a different condition, although these patients are also very poor in terms of response to intravesical BCG. But those who are really very keen and understand and ready to follow up is one group in which you can have an extensive TUR, create a little fossa in the prostate, make their bladder neck incompetent, and start intravesical BCG and monitor them very closely, because CIS is notorious for metastasis and CIS is notorious for upper tract involvement as well. So we need to be really very, very careful in terms of treating these patients. Let's move on to the next case. This is a 73-year-old lady. She saw a gynecologist for routine evaluation and basically for lower urinary tract symptoms. This is also a practice in Pakistan that majority of women with urinary symptoms end up with a gynecologist. She's a former smoker with 30-pack year history. She has not had any major surgery. The urinalysis indicated microscopic hematuria. So the urogynecologist actually performed an office cystoscopy and saw a large growth. And that was the point when she was referred for consultation. And you can see a big tumor. And this is her CT scan, which are essentially showing a normal upper tract. Both the ureters were fine, but she's got a huge growth on the left lateral wall and part of the anterior wall of the bladder. So at this point, considering that she's got such a huge growth, and it's very unlikely that she would be cleared of the tumor, let's go on to the next poll. And what are the options once after a flexicysto, she's been referred to you as a urologist to take care of this tumor? So the poll is open now. Please vote.
Professor Matsa, we have initiated a momentum now. The inertia is working.
Yeah, I mean, response, and I'm really very, very happy the way our audience have responded to these difficult situations. I mean, these are not run-of-the-mill cases that you get every day. These are slightly the next stage cases.
Another comment to the audience that we are all learning and evolving. We all want the best for our patients. So if we come across a difficult situation, no harm in asking a colleague, what would you do? At the end of the day, you want the best for your patient.
Okay, so I'm going to end the poll now. About 60% of our audience have voted. And this is the outcome. 60%, nearly 60% feel that a good TUR and should be done and see how much you can resect. The 40% thinks that irrespective, even if it is a low-grade TA disease, because of the extent of disease, a radical cystectomy should be offered upfront. It's open for my panelists to kindly enlighten us further on this, what they would do.
So I'll just comment, Professor. I think it's again a challenging situation, as you have highlighted. Chances of clearing this tumor in a woman whose bladders are more prone to have bladder perforation. So you need to be careful what you're going into. So I think the aim is to diagnose it optimally. You need a tissue diagnosis rather than keep digging and going outside the bladder. That will be my suggestion. And assess the patient regarding the suitability of major undertaking, involved in a multidisciplinary approach. And I think we have, in my opinion, if the patient is a suitable candidate and proactively motivated patient, radical cystectomy is the way forward out. Thank you.
So let's see what was done, and then we can, I think, discuss it further. So the first TUR lasted 3 hours. Continuous bladder irrigation was required. The patient, normally I discharged them on the same day. She required 2 days of in-hospital stay with continuous bladder irrigation. And then subsequently counsel her about TURP versus radical cystectomy. Second TUR lasted 1 hour and there was complete resection. She had high-grade T1 cancer with appropriate muscle sampled and no muscle invasion. Dr. Reber, would you like to comment? Would you have agreed with this approach?
Yes, yes, it's a all conservative. I love conservative approach because patients loves this way to of not having destroying surgeries. But basically, yes. So it was a commitment. It was a big commitment because 3 hours endoscopic surgery, even for now, we all of us we are seeing we are watching the screen, but sometimes you are stuck your neck and you can get back pain after these 2 sessions we need to think about us as well. But yes, definitely it was a good job. It's a patient that is going for BCG. I think so. He'll start. She will start the way of BCG, and yes, so it's a good job. It's a good job. I wouldn't I wouldn't have done as a first treatment, first line of treatment, the radical cystectomy. Sure. Um, because it's maybe is matter of with these bulk tumors is matter of time, and of course the risk of complication are higher, but we still we can try.
Marco, there's a very interesting question from Irfan Al-Bariti, and he says that would the management would have changed if she would have presented with gross hematuria requiring multiple transfusion after the first TUR?
Another. This is a possible complication. Yes, that's why in a patient, I don't know, but in my opinion, these bulk tumors, okay, it's out of the guidelines. We all agree that is out of the guidelines and neoadjuvant intravesical therapy. But in my opinion, in the day by day practice, is something that may help to reduce the chance of the bleeding, the tumor volume, and also the tumor complexity, because after this treatment the tumor branches are zero. Tumor branches usually sometimes they make your resection more difficult because it cannot identify the anatomy of the tumor. Then I can assure you that after, if you use a short schedule twice a week for 4 weeks, you can find another situation inside the bladder, and the tumor that can be resected only after 3 hours, maybe in 1 hour you can resect without significant bleeding risk. This is my conviction. Of course, it's not in the guidelines, but it's nothing that can harm this patient, and my help to treat her at the best of our possibilities.
Thank you very much. I have a couple of more cases, but I think I'm running out of time. I think
I just wanted to make a comment, if you don't mind. Would you take her back to theater and do another resection? Because now it's T1 high grade, or would you suggest, what was the outcome eventually of this patient?
this patient, after the second TUR, had complete resection, and following which I waited for 5 weeks and started her on BCG. She had muscle sampled on both occasions, and they were both negative on the first and the second TUR.
So I think this is the message to the audience. If you have twice sampled the muscle and it has been clear, this is a disease you don't want to wait too much, because that's why I think once you have good sampling, you have endoscopically cleared the tumor and muscle has been cleared, go for BCG. If the patient is not going for cystectomy, rather linger around for another redo, because you have sample, you have histological evidence. Thank you, sir.
Right. I'm really grateful to wonderful discussion that we had. Hafiz, Mazhar, Marco, you have been very helpful, and I'm really congratulate my delegates as well, who have given some really intelligent answers to these difficult situations, which even the most experienced one would get worried about. I see my dear friend, although he was stuck in an emergency, but he is here. Chris Bach, an old friend, although he's very young, but he's an old friend.
Good to
So Chris is going to take up muscle invasive bladder cancer, and he's going to talk about some really difficult situations that we face in the management of muscle invasive bladder cancer. Floor is yours, Chris. You're muted.
Okay, there we go. Dear Hamad, nice to see you and nice to see you all. Thank you very much for inviting me and giving me the opportunity to contribute a little bit. As per your WhatsApp, I have prepared a talk going more into the broad spectrum of management of muscle invasive bladder cancer than going into the depth. And we will discuss many things, but we will not go in too much detail, and I hope that's going to be suitable for the audience. Yeah, I've sent my talk already, but it might be better if I show it on the screen. Is that right?
Up to you. I mean, oh yes, we can.
There it is.
Yeah, please go ahead.
Okay. Wait a second, maybe. Do you see my talk?
We just saw it and it disappeared.
Yeah, Chris,
Wait,
we saw it, but it's disappeared now.
So do you see that now?
No, Chris.
Wait a second.
Still
I
not
will,
this.
I will
Still
work
not.
on it.
If you want, I can share with my computer, sir.
Wait a second, please. There we go. I think that should do the trick.
It is now there.
It is now. So, okay, then here we go. So as everybody know, I'm working in Aachen in a university hospital, and I'm sorry for being late. I've been dealing with some emergencies, put in a nephrostomy in a septic patient, so that's usual practice in the daily life of a urologist here in Germany, because we do the nephrostomies ourselves. Here I want to start my talk with this fantastic summary or time frame from a very nice article I found recently. It's called Landmarks in the Treatment of Muscle Invasive Bladder Cancer, and the senior author is Shamim Khan, who is very well known to you all. And you will see that with 1851, there is the earliest record for an attempted urinary diversion, and cystectomy was performed as well quite early, and even the first orthotopic reconstruction in a human was performed in 1913. So all those things, they happened pretty early, and they happened even earlier than prostate surgery. That's not surprising, because if you don't get rid of your urine, you're gonna try nearly everything to make that happen again. And then you will see that there is a time around 1919 to 2000 where not a lot of things happened. So we had, before that, we have discovered the cisplatin, MBAC was introduced, cisplatin dependent chemotherapy, then cystectomies have been performed, trimodal treatment has introduced, but there was for a significant time around the year 2000, there was a stillstand in development of bladder cancer treatments. And only in the recent years, in the last 5 years, that has picked up speed again, mainly with the advent of the ICUs, the checkpoint inhibitors, which have significantly changed the landscape of bladder cancer treatment. And that's a nice graph of how those things play into one each other. So certainly there's always a lack of public awareness of bladder cancer. There is public awareness about prostate cancer, of course, but bladder cancer is not so prevalent in the media. However, we have changed that. The German Association of Urology has really tried to make that a topic, a returning topic too, and we are dealing with that on the internet, and we have using television and radio to make people aware of the dangers of blood in the urine. Because of the lack of public awareness, of course, there was not so much pressure to fund research regarding bladder cancer. And of course, it's not a disease as common as the prostate cancer. There was poor funding, limited research, so we didn't really understand bladder cancer biology. And of course, that led to the absence of novel therapies. So that was the vicious circle we were finding ourselves in. Gladly, that has changed, as I said before. So one thing I want to highlight are the recent American Association of Urology guidelines regarding the investigation of hematuria. And looking at microscopic hematuria, we know that there are different guidelines in different countries. There are PAUS guidelines, certainly, and they all are pretty vague about the risk assessment of patients who come with microscopic hematuria, and we see that quite a lot. And you're actually, sometimes I have doubts if I'm doing enough or if I'm doing an overkill and investigating those people. And the American Association of Urology has introduced risk categories now. They talk about low risk on the left, they talk about intermediate and about high risk on the right. And they put in age, they put in smoking, they put in repeat dipstick test and additional risk factors, which I will not highlight right now. However, so they have taken up the task to create risk categories, and those risk categories, they play a major role in which kind of workup you choose for your microscopic hematuria patients. And for example, if you have a low risk patient, like in the first line up here, low risk, non-smoker, young person, you will maybe come to the conclusion that you will not perform, even if on repeat analysis there is microscopic hematuria, you will maybe come to the conclusion that you will not even perform a cystoscopy or an ultrasound scan. So this is something which I find really good, that those stratification according to risk categories is coming into the mainstream now, and the Americans have been on the forefront on introducing that. So there's another topic I want to highlight. There was always the controversial topic about bladder preservation therapies. And we know that radiotherapy alone itself is certainly inferior to surgery. And that's partly why the radical cystectomy is still the gold standard for bladder cancer or muscle-invasive bladder cancer treatment. However, after the introduction of trimodal therapy, which consists of thorough TOR of the bladder tumor, of chemotherapy, which is sensitizing the tumor to radiation therapy, and then radiation therapy, we have seen pretty good results with that. And in selected patients, they are certainly as good as patients treated with radical cystectomy. And if you look at the ideal patient, the ideal patient has a T2 tumor, not more. He doesn't have a muscle and a significantly extravesicular disease, no hydronephrosis, no carcinoma in situ, and a unifocal tumor and a good functioning bladder. And those patients, they can be very well served with trimodal therapy. And things are getting even more interesting right now, because as I said before, we have the checkpoint inhibitors, and those checkpoint inhibitors, they certainly play a part in novel trials and in novel regimens which are under investigation for trimodal therapy. And this is just to highlight a few. Those are 5, but I think there are actually at the moment more than 10 trials running. And if you can see in the first trial, for example, it uses pembrolizumab in combination with radiotherapy. There are some trials which combine pembro and gemcitabine. There are trials which use pembro and cisplatin. So all those trials have been set up in selected patients to show that with those new checkpoint inhibitors, there might be even bigger for trimodal bladder preserving therapy in future. So this is certainly a space we need to watch, and I'm very curious what will come out of that. The effects we know that chemotherapy is sensitizing bladder cancer to radiation, and the hypothesis is that the immunotherapy is even more sensitizing the bladder cancer, and that those two therapies they add to each other. And here's a little slide showing you the new checkpoint inhibitors, or some of the new checkpoint inhibitors which are actually used in different settings. In the neoadjuvant setting, as everybody will know, that neoadjuvant cisplatin based chemotherapy is standard of care, and we use that on a regular basis, but to be honest, we don't use it frequently enough because there are some considerations. For example, if you give cisplatin to a patient, you might put him into a worse state for surgery, or he might not respond and surgery might be delayed. So those are the things which make us sometimes a bit hesitant to give neoadjuvant chemotherapy. And the hope is that with those new immunotherapeutics, we will not decrease the patient's ability to undergo surgery and maybe have an even better effect in downstaging the disease before surgery. And if you look on the left side, there are all sorts of different checkpoint inhibitors and combinations used, and this is certainly a very interesting thing to watch for the future, and I think our patients will benefit significantly. Same is true for bladder sparing therapy. I highlighted in the slides before, and something we have been looking at certainly is adjuvant therapy, and we are participating in the Checkmate 274 study, and we are trying to find out if there is a benefit for our patients getting adjuvant immunotherapy. We here in Germany, we sometimes, or not sometimes, we not infrequently give adjuvant chemotherapy. I don't know how you guys are doing that, but this is something we do or we see not too rarely here, and we have even some significant personalities in urology who heavily propose that. Okay, going a bit further, this is one of the topics dear to my heart. This is robotic surgery, and robotic surgery has certainly an undisputable place in urology at the moment, and it has clearly taken over radical prostatectomy. However, for radical cystectomy, the jury is still out, and there are many attempts to find out what is the evidence and what is the actual truth. There are some experts promoting robotic cystectomy as the new gold standard. There are other experts saying that there are significant risks involved, and that robotic surgery is not yet there or will never be there. I'm a bit in the middle. I perform robotic assisted cystectomy and intracorporal diversion, and I think for selected patients this is a very good operation. However, I don't think it's the holy grail of surgery. I don't think robotic assisted cystectomy is in itself the game changer we've been hoping for, or I've been hoping for. It is not. If you perform a good open cystectomy and you have an enhanced recovery protocol, I think your results are as good as they will be with robotic surgery. I think robotic surgery has some advantages, and I'm going to highlight them in the next few slides. And this Cochrane meta-analysis is an example for the other meta-analysis you can find on the net. They're all coming to similar results. And only to show you how difficult it is to get some quality data, they had a significant search number of 116 records screened. They broke that down to 32 full text articles assessed, and finally they had 5 studies which they could include. This is not really a lot, and it's difficult to generate some high quality evidence with that. Here we're looking at the primary outcome, that is the recurrence-free survival. And if you look at the black sign here, you will see that this is not in favor for either one of the approaches. So I think the conclusion should be that from the oncologic point of view, there is no significant difference. major postoperative complications, as I highlighted before, or as I pointed out before, cystectomy, regardless how you do it, is an operation which has significant complication rate, about 30% of major complications, and I didn't see that really decrease with robotic surgery, and it depends on which expert I talked to. I've been to the MD Anderson in Texas, and they performed mainly robotic assisted cystectomy, and they did that very well, and they were swearing, not they were confirming that they had a very low complication rate. However, for me, certainly that's not true. I think the complication rate is nearly the same as for open surgery. And this is what this comparison or meta-analysis confirms. You can see that there is no benefit for either. And if you look at the authors' conclusions, they say that outcomes are oncologically wise the same, rate of major complication is the same as well. Probably reduced transfusion needs, reduced length of hospital stay, and if there are really less minor complications, this is unclear, and I would completely agree with that. You lose less blood, that is for sure. People are quicker out of the hospital, but it's still a very morbid procedure. And one of the problems we need to highlight if we are looking at those studies and those meta-analysis is that a cystectomy, taking out the bladder, is only half the operation. The other half of the operation is performing the reconstructive bit, and we all know that as soon as the bowel gets involved and as soon as you have potentially a mix up between urine system and bowel system, you can run into, or your patient can run into major trouble. And all those studies have been conducted with an extracorporeal diversion, meaning robotic cystectomy, and the diversion has been extracorporeal. And I think we still need to wait for a study where you perform a robotic cystectomy, a robotic diversion performed at expert centers which have gone through their learning curve, and you compare that to an expert open surgeon. Then I think we will come a little bit closer to the truth. Okay, leaving the modality of surgery behind, having a quick look at lymph node dissection. And as everybody knows, and as I've shown before, lymph node dissection is an inherent part of cystectomy, whatever way you do it, regardless if you do it open or if you do it robotically. And I myself perform as I call it, normal lymph node dissection, meaning I take out the external iliac nodes, I take out the internal iliac nodes, I took out the obturator fossa nodes. I usually don't take the presacral nodes, and the ureteric crossing is my medial border. I don't know how you guys are performing surgery. Hamad, you're nodding a bit. Is that the way you're doing it as well?
Yeah, standard lymphadenectomy, unless there is a abnormal lymph node, then you move to the extended lymphadenectomy. So I do what you do.
Yes, and I think for good reason, and I think majority of surgeons is performing that as well, because as we know, lymphadenectomy can first prolongs operative time. Secondly, it can lead to significant complications. I recently had a guy after a prostatectomy who came to me. He had the biggest lymphocyte I've ever seen. The whole kidney was encased in the lymphocyte. So the lymphocyte was coming from the pelvis and basically pararenal lymphocyte, which I drained. It was 2 or 3 liters. That was significant. I've never seen that before. I've seen strictures, ureter strictures or compression by a lymphocyte. So it can have a morbidity, and I think it's better to avoid that. There is some evidence out there that the more lymph nodes you take, the better the oncologic control is. However, number of lymph nodes and the templates are not clear, and we certainly don't have a sentinel technique right yet where we can pinpoint the lymph nodes we need to take out. So this is lymphadenectomy. I performed the standard template, and I think this is in line with most surgeons. Urinary diversion, I want to touch quickly on. So as yourselves we're performing all sorts of urinary diversions. In Germany, we are pretty prone to perform complex reconstructions. So we tend to offer quite a significant number of patients a neobladder. The reason is that, first of all, we think that neobladders are underutilized, usually because they are contributing to surgical morbidity, and they are a little bit more difficult to perform. And secondly, we have an incentive in Germany, which is at the end a financial incentive as well to perform new bladders. So we are a little bit more or less restrictive than other countries, for example, where people purely look at morbidity, for example. And we hardly perform pouches. So I myself, I don't perform pouches. I have very little experience, and I know very few people who do that. How's the situation in Pakistan? Do you perform pouches on a regular basis?
Chris, I was recently reviewing my last 300 cases, and there were about 60 orthotopic neobladders, and a couple of Indiana pouches, a couple of cutaneous ureterostomy, and the rest were all ileal conduits.
Okay, if I would review mine, you have a very good number of neobladders. That's impressive. If I would review mine, I think it would be the same, apart from the pouches, which I don't do, and we would perform a few more uterocutaneostomies. This is something we have very old, very frail patients sometimes, and we say, okay, let's just take out the bladder, do that quickly, and patient comes for a regular mono-J exchange to our hospital. So this is what we do frequently, but of course, conduits are the mainstay. Are still the mainstay. They are relatively easy to perform. Morbidity is not so high. And my personal experience is, in the end, it doesn't matter. Patients who have gone through the surgery, who come back to you and who are cured from their disease, they say, regardless what they have, they say with the conduits, they say, I'm fine. I feel great. It works well for me. And they know it's not a joke, and they know it's there for a reason. And we performed life-saving treatment, and they're usually happy with that. At our institution, we perform 2 neobladders. I personally performed the Studer neobladder, which was invented in the 80s. And a colleague of mine performs the Hautmann bladder in this W shape. And we agreed, what is rare, that 2 surgeons agree that the Studer neobladder is a bit easier and a bit quicker to perform, whereas the Hautmann neobladder might have advantages because you have an implantation of your left and right ureter on opposite sides. So the rate of stricture might be lower. And if you have a very, very short ureter, for example, especially on the left side, there might be technical advantages because you can more easily have a longer pipe and make your implantation on top of it. So those are the 2 main neobladders we use, and it really depends on the surgeon who is performing the surgery which one we take. So coming now to another topic which is dear to my heart, and this is the molecular classification. Excuse me, please. It has been a while that I spoke in English. There was, as I've shown you before, a significant lack of funding for research, lack of interest. That means that those things like digging deep into the genomics of bladder cancer hasn't been done yet. We do that at this university hospital here because our chief pathologist, he is Frau Professor Knüchel-Clark. She's very keen on bladder cancer and is bladder cancer specialist. And we take part in these studies where we try to match molecular subtypes with clinical outcomes. And that, I think, is the next step. So the first step was to identify, for example, non-muscle invasive cancer, the class 1, class 2, and class 3 subtype. And For the muscle invasive cancer, there are 6 subtypes like luminal papillary, luminal non-specific, luminal unstable, stromal-rich, basal squamous, and so on. It's not really necessary to know them all by heart right now, but it's necessary to know that on that realm of molecular subtyping, there's a lot happening, and that the future will certainly be that we can give a prognosis of the patient's course of disease according to the molecular subtype his muscle invasive bladder cancer has. And we will as well be able to tailor treatment. And we will know that one patient will fare better with upfront cystectomy, and the other cancer will fare better with upfront cisplatin-based chemotherapy, and the other patient will fare better with upfront immunotherapy. We will know that in future, hopefully. And this very busy slide, excuse me, please, gives you an overview about the different types or molecular subtypes of bladder cancer. If you look to the left, the green pathway, though this is the non-muscle invasive bladder cancer. Of course, about 70% of the bladder cancer is non-muscle invasive, and it usually starts with hyperplasia. And then you have the class 1 subtype, class 2 and class 3 subtype, which develop the non-high grade, non-muscle invasive bladder cancer. And in the middle, you have the hyperplasia with dysplasia or carcinoma in situ. And this is the pathway going to the high grade non-muscle invasive bladder cancer. And this is usually the class 2 subtype. And then you go to the other side where you have the muscle invasive bladder cancer, and the muscle invasive bladder cancer is about 30% of the bladder cancer we see. And here in the muscle invasive bladder cancer, you have the different subtypes, like to highlight the first one, basal squamous subtype, or the other one, neuroendocrine-like subtype. And all of them, they have their special type of mutation, amplification, or gene loss, like EGFR amplification, TP53 loss, etc. And those subtypes will certainly guide our treatment decisions in future. And this is something I'm very keen on to see that come from theory into reality. So, and a little bit of that has already emerged or found its way into the guidelines, into the ERU guidelines, for example. And this is the PD-L1 expression status, and we usually use this status to see if there's pembro or atezo, which is a good treatment option for the patient. And if we are at the end of our treatment pathway and patients have a poly-resistant bladder cancer, we look at the FGFR2 or 3 genetic alterations and try to determine if adagrasib or PARP inhibitors in general will be a good option for this patient. So I think I'm coming to the end of my talk right now, where I wanted to give you more or less an overview, and I tried to summarize that on my last slide. So of course, for diagnosis, I think the previous talk by Mr. Scheik was about TURBT, if I'm not mistaken. So of course, you need cystoscopy for evaluation of cross hematuria. Then you need a thorough resection. You might need a re-resection. If you think this is muscle invasive disease and you're thinking in the back of your mind, you might perform a neobladder. You want to check out the urethra. You might want to take biopsies from the prostatic urethra. Of course, there's the imaging, the complete staging, which is important. We usually do CT, thorax, abdomen, pelvis. I'm sure you're doing the same. And if the patient finally has a muscle invasive tumor on his histology, we first try to make a decision: is there any role for neoadjuvant chemotherapy? We know there's a survival benefit, but as I pointed out before, there are some pitfalls to look out for. Very fit, very young patients with not a very small disease, which have a rather high burden of disease, we usually give neoadjuvant chemotherapy. Small disease burden we usually don't give, and old patients we usually don't give either. Radiotherapy, as I said before, is not recommended. Immunotherapy has at the moment no guideline conform outside of the trial setting status in a neoadjuvant setting. If we proceed to radical cystectomy, of course, there's the need for a meticulous preparation of the patient. You will need to have an enhanced recovery protocol in place in your hospital to have optimized outcomes. The surgical technique, if you do it robotically or open, does not really play the significant role. Of course, you need to perform a lymph node dissection with your cystectomy. I personally think, and I think most experts are going to agree with me, a standard lymph node template is sufficient. And of course, the caseload I didn't touch on yet. In Germany, we have, as well as in every other country, a movement to concentrate cases and caseload in bigger referral centers. And although the system here is competitive, you of course have regulations in place which try to make sure that we perform at least 50 cystectomies yearly in our hospital. And I think this is a number you need to not only to be good as a surgeon, but as well to be good as a whole team, to be good as ITU personnel, to be good as nurses on the ward and junior doctors to know what you're actually doing. And the last point on that slide is the adjuvant chemotherapy. And as you know, we tend to give adjuvant chemotherapy. Something I want to highlight now is that in patients who have stable disease on cisplatin-based chemotherapy, we tend to give avelumab, which is a checkpoint inhibitor, which of course you will know that has shown to stabilize patients with advanced disease. So I think I'm at the end right now. I'm happy to take any questions, and I hope you find one or the other slide useful.
Right, Chris, thank you very much. I think that's a very comprehensive overview in a very short time, and I'm really grateful for your very interesting presentation. I would request your presence for the panel discussion on muscle invasive if you're not have to go back to the OR. So I really appreciate if you can stay back for this panel discussion. And I have few muscle invasive cancer patient, and I would request Mazhar if you can stay back. I think your input would also be very helpful. So if you can stop sharing, Chris, I'll share my slides.
Sure. I will need to mute myself and just make a call, and I'm hopefully to be able to join in a few seconds. Did Great. I stop sharing? Did I stop?
Yes, you have.
Okay. I'll see you in a second.
Sure. Okay, so there's a question about neoadjuvant chemo prior to radical cystectomy, and I'm going to take this this part in my presentation and in the cases that we discuss. So I'll start off with the first case. So this is a healthy appearing 55-year-old gentleman who presented with gross painless hematuria. He has a 15-pack-year history of cigarette smoking. CT scan showing a posterior wall tumor. He had TURBT and a single installation of MMC. The histopathology showed a high-grade T1 cancer, muscle present but not involved. So it's a true PT1H high grade. However, he developed severe frequency and urgency a couple of weeks after his TURBT. His cultures have been negative and he has not responded to anticholinergics. So he was given one after the other anticholinergics and he didn't respond. So Sharif, can you share the first poll? So just to summarize, 55-year-old high-grade urothelial cancer, non-muscle invasive, develop significant frequency. Kindly vote now. Okay, so maybe a couple of seconds more and then we'll close the vote. Please vote now. So more than 50% have already